Hey guys, Woodruff here. This next video is going to be over level of consciousness versus orientation, and is really going to be getting more into neurological assessment. So a lot of the stuff so far, you may be like, okay, but where are we going with this? Because it's just concepts. But these concepts are going to help you with everything we're going to do moving forward in future sections. So, with this, first we need to talk about what the difference is. So most of the time when you're getting report and things like that, what you're going to hear is you're going to hear the nurse say, "Yeah, they're alert and oriented times 4," and that's talking about both. That's talking about level of consciousness and orientation, because the alert part talks about level of consciousness, and orientation is that they're oriented times 4. But it does, when I was a student, and most of the students that I interact with, they don't really know the difference. And if I ask them what's the difference between level of consciousness and orientation, they struggle, because level of consciousness, they'll say like, oh, like times 4, but that's actually orientation. So the difference here really is going to be in is that level of consciousness is how awake you are, where orientation is going to be about how aware are you about what's going on. So think how awake you are and then how aware you are. And this is really important. If you're wondering, and maybe I should have said this first, you will be tested over your Glasgow Coma scale, and you will have to scale these people. So this is a very important video to watch. If nothing else, you're going to have to understand through future classes, and understand what the GCS says, because what someone's GCS is going to be very important for you, and what do you call it, in life, because we do this to measure and scale how people are doing. What someone's GCS is tells us a lot about how they're doing overall. So let's attempt to change slides. All right. So like I said, with orientation, the first A, or I should say the A's in the alert and oriented times 4 are all about how awake they are. But the times 4 is orientation, or how aware they are. So the four parts there are: they oriented to person? Can they tell you their name and date of birth? That one's pretty simple. Um, Oriented to place. Now, if you tell them, "Hey, do you know where you are?" Here's the thing, is like it's usually the worst way, like, "Hey, do you know your name?" Like, or "Do you know where you are?" They're gonna be like, "Yes." So, especially if they're a smart ass. But the better way to ask this is, "Can you tell me your name and date of birth?" Where are like what do you call it? Where are we? Instead of saying, "Do you know where we are?" Because they're just gonna say yes. Where are we? And if they just say the hospital, that's great. But I've had patients that say the hospital and say, okay, which city or which hospital? And then they'll tell me like, oh, Alvarado, or they'll be like, yeah, I'm in Abilene, or I'm in Houston, California. I've gotten some pretty interesting answers. So just because someone knows they're in the hospital doesn't necessarily mean they know where they are. So always wanted to be specific there. And then most of the people is like, what is today? Hell, I don't know what today is. So I usually say, if you know the month, you're doing pretty good. Or sometimes if it's been a recent holiday, hey, do you know what holiday's coming up? Or do you know what holiday just happened? Just something to kind of tell that they know generally what time it is. You can ask them the year, but someone could be in the year, but very far off from where we're at. They could be in December and it is in July. So I usually say the month is a good, a better way to tell if they're pretty close with time. And then situation. So do you know why you're here? Like, and again, maybe not ask, do you know why you're here? What brought you to the hospital? And so things like that. Now, a lot of people love the president question. I know you guys learn this a lot, but one is very controversial because people do not like to mention, politics and stuff like that. So you're about to earn yourself an enemy, depending on if they like the president or not. But two, someone could know the president, but we have the same president for multiple years. So is this really a good measure of how they're doing? And so, I mean, sometimes I'll even take like, hey, what's been going on recently? And if they can tell me, like, if they're telling me about the family drama they've had going on and blah, 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 and I know I can confirm that that's true, then hey, they know what the situation is. Even it, like, they don't have to know it perfectly. Like, they could tell me, yeah, like, I'm here for my heart. And even if it's not really 100% there, that if they're in the ballpark, I give it to them. But yeah, effectively, you want to see, do they know who they are, which hospital they're in, and what city. And even if they don't know the city, at least if they know the name of the hospital, etc. And then are they, and these all have levels, but I'll give it to them most of the time if they can tell me they're in the hospital, and they have a general idea of where we are, what month is it, and then why are you in the hospital? Then there's level of consciousness, and this specifically focuses on how awake a patient is. And so, in order to measure this, the most common one used in most hospitals is what's going to be called the Glasgow Coma scale. And this measures LOC or level of consciousness. And effectively, it's telling us how much does it take to get a patient to respond? Like, how hard do I have to work to get a patient to respond? And we scored them in three different categories. We scored them in eyes. How much stimulation does it take for their eyes to respond? How much verbal stimulation are they able to do? And what is their motor response? And like I talked about in my last video, when I talked about increased ICP, usually the first sign of a problem in the brain is going to be a change in level of consciousness. This is why this assessment is so key, and you really want to learn this. Now, in the hospital, you're going to have, a nice little, thing in your charting you're gonna like use this little, like drop down menu, and so you can easily do it. So you don't necessarily have to do the math. But here in nursing school, we want you to do the math. Now, one thing I want to say is this is we're learning these different scores and scales and stuff like that is we are not trying to trick you and say, what's the difference between a 7 and an 8? But we do want you to know the difference between a 3, a 7, and a 15 because there's a big difference there. So if you had a question where we want you to score someone, we really just want to make sure that you understand some of those basics when it comes to how to score people. So the answer choices are not going to be like really tricky ones where if you're a little off, if you most of these, like if someone tells me generally, like gives me a description, I can tell like they're not awake at all, they're kind of awake but they're not all there, or they're pretty awake. And so that's really where we're trying to get you to be at in your assessment. So the first part of the GCS is eyes. And the way that I remember this, by the way, too, because I don't think, well, maybe I should add a little that somewhere else, but the minimum score you can have for a GCS is a 3. So like everyone at the minimum will have 3 points. And so because they get a 1 for each of the three categories. The maximum score a person can have is a 15. And the way that the scales go is there is a maximum of 4 points for eyes, a maximum of 5 points for verbal, and a maximum of 6 points for motor. So if you can remember 4, 5, 6, it might help you as you're studying this. So GCS, like I mentioned, is one of the first parts of the scale that we usually do, and this is seeing how much stimulation does it take to get someone to open their eyes. The highest they can have is a score of a 4. The lowest they can have is a 1. So kind of going through the highest, the best response, the one that, and I'll talk a little bit about this later, but I mean, we always grade the best that we saw. So like if in my assessment, like at one point they were doing one thing, at another point they were doing another, like for how well they were responding, I will grade them on the best that I saw them do. So opens eyes spontaneously or a score of a 4 would be is if I walked into a patient's room and they turned and looked at me. I didn't have to say or do anything to get them. They can open their eyes all by themselves. A 3 is opens eyes to voice. So this would be a patient. I do not mean a patient who's sleeping. Like you go in at 7 o'clock in the morning, you go in to do your assessment and you're like, oh, I had to wake them up. They were sleeping. They're not a decreased level of consciousness. Now, if you have a patient that you go in their room, no matter whether they're asleep or not, and you have to say something like, hey, Mr. Johnson, and it takes that to wake them up, every time. Like these patients are usually going to drift right back off. You say, "Hey, Mr. Johnson." They open their eyes and look at you, but you're not going to be able to usually keep their attention, or it just takes a little bit more. This is not a patient that is sleepy usually, sleeping, but it's a patient who is very sleepy or drowsy, and it's just taking that extra. Like their eyes are not going to open on their own. You have to verbally stimulate them. But hey, call their name. The next level is opens eyes to pain. And so what this would be is you don't need to go and start doing a sternal rub on them. We always start with the least stimulation first. So I start with the tap on your shoulder. Hey, Mr. Johnson, can you hear me? And if that's all they need to open their eyes, then if that's what they need to open their eyes, then that's going to be a 2 for me. It's requiring more than a voice. It's requiring some more stimuli. Now, let's say they don't respond to the tap, then I'll try like a pinch or something on the hand, and then what do you call it? The most stimulating would be like where I do something like the trapezius pinch, where I pinch here on their muscle, the sternal rub, or there's the supraorbital notch, which we'll talk more about that, where you can put pressure. So that would be all under 2. And then the last, or the lowest score would be a 1, which means they do not open their eyes. It doesn't matter what I do, they are not opening their eyes. Now, sometimes there's other reasons someone could be like this. They could be sedated, have other things going on, but we always score what they are. So, and then there's usually like a comment box, like maybe there's some reason that they have a lower score, etc. So, pretty much you go in, if they're opening their eyes by themselves, great, they're a 4. If it takes you talking to them in order to get them to open their eyes and they're not asleep, then it's a 3. If it takes some sort of painful or other physical stimulus like a tapping, pinching, or a central stimulus like a sternal rub to get them to open their eyes, it's a 2. If they don't open their eyes, it's a 1. The next part of the GCS is the verbal. The highest score that they can have for verbal is a 5. Remember, eyes is 4, verbal is 5, motor is 6. The lowest, again, they can have is a 1. So this scale is all about in orientation itself, you don't have a level of consciousness, but within this level of consciousness assessment, we do check orientation. So GCS is not just about their verbal abilities, it's that they're able to talk and make sense too. So the maximum or the highest or the best verbal response is someone who's not just someone who can talk, but someone that can verbally respond appropriately. So a 5 would be someone who's oriented. So if I go and talk to someone and they're able to answer all my questions appropriately, they would be a 5. If they're able to talk to me, they have verbal abilities, but they're not making sense. They are disoriented, confused, and like they're not answering questions appropriately, they would be a 4. 3 is words, which means like it's the difference between 4 and a 3 is 4 is someone who can speak to me just like I'm speaking to you, but they're not making sense. And it doesn't mean that they have to be as verbose and stuff as I am, but what I mean is that they have the ability to try to answer questions. Someone that's a 3 is someone who only has a couple words at a time. It's like hungry or like sleepy or what's going on, or like they're just very like, and most of the time it doesn't make sense. Like, so it shouldn't even be like what's going on. That would be more like confused. But like a good example would be someone who's just sitting there and like repetitiously saying things, like where they're just saying words like mom, help, oh, no, like, like they're just saying 1 or 2 words at a time, and that's all they have. They're not answering any of your questions, really giving attention to anything you're asking them. They're just saying 1 or 2 words at a time, and again, it's usually very, it's things that don't make sense. Then there's sound. So these are people that are not using any words, they're just making sounds. So just be like, "Oh," you might be talking to them and they're not actually answering, they're just, making noises. And then 1 would be no verbal response. We have someone who's oriented, we have someone who's confused, who's answering questions but not answering them appropriately. Someone who has words, only a couple words at a time, but usually they don't make sense or not applicable. They're not answering your questions. They just have a few words. And then sound, someone who's just making noises, but no words are coming out. And then again, 1 is they're not talking at all. So those 2 are pretty easy, but this last one sometimes people struggle with. And I have a video that obviously I'm not going to show in this video, but I highly recommend watching, is see someone go through and do this, because it makes a lot more sense when you can actually visualize it. So for the motor, the highest they can score, is a 6. So remember 4, 5, 6. So eyes is 4, verbal is 5, motor is 6. The lowest they can have is a 1. So to get a 6, motor is not just about having motor function, it's ability also mentally to understand and do a command. So this is what I was talking about earlier, is I want someone to be able to hear what I'm saying, and their body their mind, their brain comprehends what I'm saying, and they can actually complete the command. So that's why I like thumbs up, raise your eyebrows, stick out your tongue, something that's going to really take them understanding it. Lift your head off the bed, things like that. I don't like hand squeezing or wiggle your toes, because sometimes people can do that reflexively. And I believe it or not, I've had it happen right at the moment where I was like, wiggle your toes, and their toe moved a little bit. But then I found out later that then I was watching them for a while and they were doing it like pretty repetitiously. I think they were having a seizure or something. 6 would be that they can, follow my, at least like I usually try 2 commands. If they can do only one, great. And don't try to throw a lot at them. Sometimes like I did the same thing when I first started, where I would sit there and I'd be like, okay, try this. Okay, we'll try this. We'll try this. Can you do this? Can you do that? Like just give them a little bit at a time. Because remember, this is a person usually with a neurological problem. Number 5 is localizes. So this is, think of it this way, is that the person senses a stimulus and then it recognizes it doesn't want the stimulus and pushes it away. So we usually, like, you might hear about people doing nail bed pressure. And there's still sometimes I do this, but in reality, it's kind of unsafe because there's a lot of diabetic patients. The nails are a very sensitive area, so you want to be super careful. So I usually recommend staying away from nail bed pressure, and a better thing to do, sometimes I do like a little pinch, or I mean, again, I should say this. I always start with the tap first, like tap, 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 see if they wake up. If they don't respond to that, then on their extremities, what I do is I like maybe do like a pinch. I'll pinch their skin. Now, localizing would be them pushing away my hand. Like if I start pinching and they push away my hand. Like that's they have higher brain function because their brain is saying, I don't like the stimulus, get it away. That's a 5. The next one is a withdrawal. So that same stimulation, like let's say I tap, don't get any response, I pinch. That's them, they pull away. A withdrawal, think they're withdrawing or pulling away from the stimulus. So remember, the localizing, they're pushing towards it. The withdrawal is pulling away. Another good example of this localizing would be like when I have intubated patients and I brush their teeth and they're reaching with their hand to try to stop me from brushing their teeth. Withdrawal would be as I'm brushing their teeth and then their arms are like pulling away. So it's like, it's still a motor response, but it's not the one I really want. Like running away from a stimulus is not really how the brain's supposed to work. If it doesn't like the stimulus, it usually should push it away. Hold on a second. I'm getting nonstop text messages. Okay, just making sure everything's okay. All right. So the next 2 are really low level of functioning. It's what's called posturing. I talked about it in my ICP video. And this is where you get to the point where your brain is just operating on reflexes. So with these patients, you can either have decorticate, and I always think that you're turning everything into your core, you're protecting your core. Decorticate posturing, it's slow. So this would be a patient, again, I'm like pinching or doing some sort of stimulus to stimulate a motor response. What they do is they tend to take their hands and they kind of slowly curl them up, and then like you can see in this picture, their feet cross, like so their arms kind of go in and they're protecting their core. And that it's a reflex. So sometimes family members see this and someone has a very low level of brain function. They're like, oh, they're moving. And I have to, tell them like, yeah, I see that they're moving. And I just explain it's like a reflex, like, when you put a pen in a baby's hand, how it will grab it. It's the same kind of thing. The lowest level before a 1 is what's called decerebrate posturing. So this is, instead of that slow inward, it's a slow outward where they're pushing and extending their arms out, like you can see in the center in the picture, and then the feet are pointed out. So I think like decorticate is better because they're still protecting themselves, where decerebrate, they're no longer protecting themselves. And then, it has flaccid here, which would be like a 1. They have no motor response. So like I mentioned, usually I start with tapping first and see if I get any response. Then I try pinching. If I need to do harder pressure, like nail bed pressure, I will. Because you need to check in all extremities because it can vary. Sometimes one extremity might do one might do another. So I want to see what their best is, remember. And then if I can't get any response that way, I mean, the thing I usually like to do with my intubated patients is like brush their teeth, because people hate that. I'm not saying go into random people's mouths and brush their teeth if they're not intubated, but we have to do it as a part of our care anyway, so that's why I do it that. But something that might be better for you to do in like a med surg unit, if you have a patient like this, would be to there's a couple different things you can do. You can do what's called a trapezius pinch. Let me see if I can show you. So you go on the shoulder, you like in the groove like by the shoulder, right, really by the neck. You put your thumb in it. It's really hard to show. You'll have to Google trapezius pinch. But pretty much you're pinching, you're putting your finger against the trapezius muscle, which is like in your collarbone, effectively, like above your collarbone, and you put your thumb in it, and then you're pinching the back muscle. And this can be very painful. So you squeeze, and I start with like light pressure, and then I do gradually harder pressure, and then sometimes I do that pinch and then they're actually responding in a different area. Like they're going to be responding, like doing the posturing. So that's pretty much, I'm trying to see how they respond. Now, if I do that pinch and they withdraw their hand, or if they, let me start with the top. So let's say I do this pinch and then they push my hand away. That would be a localizing. If I do the pinch, they pull away. That's a withdrawal. If they start the posturing, then I'm just looking for what direction they're going in. If you don't like that one, there's the sternal rub. I always hate the sternal rub. That's where you literally take your knuckles and rub it against their sternum. It's really painful. You kind of push down. You have to be super careful and make sure they haven't had like open heart surgery, stuff like that. And then the last one is like if you feel across your eyebrow, like near, kind of like a little bit in, you should feel like a notch. And if you take your thumb and push hard, and this will like almost elicit like a headache. You can try it right now if you like to cause yourself pain. You already chose nursing school, isn't it enough? And so what do you call it? And I'm sorry, these intrusive thoughts like come out of nowhere. I swear, like I don't have like a script. I'm not a comedian, but I think that I just have really deep, dark humor, and so these things come out. This is why I don't have a lot of friends, because they can tolerate me for like a certain extent. I also don't like people, but yeah, they can only tolerate my jokes for like so long. So this is what happens. But anyway, so you're pushing in, and this is what we call a supraorbital notch pressure, and effectively it can elicit the same responses. So I start always like light, and then I push harder, and then I'm looking to see, are they trying to push me away? Are they pulling away from me, or are they posturing? So yeah, and then if they have no motor response, no matter what I do, it's a 1. So there's this great video, and I think it's by someone in the UK. I was waiting for it to clear up and tell me, yeah. So it's this, yeah, if you look at this, this video, I'm sure you could find it just based on this name here. I find it super helpful to see it in practice. So the key principles here is we want to score them on the best they can do. So like if one arm is doing one response, another one's doing another, whatever the best is, like I brought up. Least invasive first. So we always start with a gentle tap or touch, then go for the pinch, sharp pressure, or the deeper, harder, like core central stimulus. You definitely don't want to go in and you don't know if a patient's awake and you start, pushing on their chest and doing a sternal rub. And then always score what you see, like regardless of what the person before you put, these subtle changes can make a big difference. So you definitely want to put those changes as you see them. I think I have some scenarios. All right, so let's get some practice. Let me move my face out of the way. So the first scenario here is the client opens their eyes spontaneously, they're confused, and they localize to pain. So for each of these, remember I'm thinking 4, 5, 6. So open eyes spontaneously, that sounds like a very high response. So I believe they're going to have a 4 for that. Client is confused. So that one, that's not the best. That's for verbal. And the highest you can get for verbal is a 5. So I think this person also, that's a 4. So it's 4, 4. And then localizes to pain. That would be that's not the best because they're not following commands, but localizes is better than withdrawals. So that would be a 5. So they have 4, 4, and 5. So 8 plus 5 is 13. So that is a GCS of 13. So they're pretty awake. They're confused, but they're opening their eyes themselves and they're responding appropriately to pain, but they're not necessarily following commands at that level. All right, this next one, client responds only to pain. So that's a low level. When it comes to their eyes. So the maximum is 4, the lowest is 1. And so, but they are having some response. So this would be a 2 for eyes. The client is making incomprehensible sounds. If you remember for verbal, it's 5 is commands, 4 is confused, 3 is words, 2 is sounds. So they've got a 2 and a 2 so far, and then no motor response, that's a 1. So 2, 2, and 1 is going to be a 5. And by the way, if I do any of these and my math is off, you can laugh at me and just comment that I'm an idiot. It's okay. I definitely am. I kind of am paid to do some sort of math teaching you guys, but it's not my strong suit. I'm definitely going to pay someone to do math with my child, or thankfully my husband's an engineer, so he can do that. All right, so client does not open eyes to any stimulus, so that's a 1. Client has no verbal response, that's a 1. And client has no motor response. This is the easy one, that's a 1. So what do I have? A GCS of 3. This is the lowest they can be. All right, so the next one, client wakes up to speech. So that's going to be a 3. Client has some words but is not making sense. So that's also going to be a 3 for verbal. And client withdraws to pain. So 6, 5, 4. That'll be a 4 for motor. So they got 4 plus 6, which is 10. Let me try to say that right. Yeah, 4 plus 6. Yeah, because 3 and 3. Okay, yeah, just making sure I'm doing math. See, now I'm doubting myself even more. I need to stop psyching myself out. Just like I know you guys do it on exams too. It's the worst, isn't it? So a 10. So that's a GCS of 10. Last one, they open their eyes spontaneously. All right, that's a 4. They're oriented times 3, or really, I know it probably should say times 4, but you get it. They're oriented is the point. So that is a And yeah, I'll have to update this to make sure because I know that y'all are so nitpicky with this stuff. It's meant to be times 4, so they're completely oriented, so that's a 5. They obey commands, which is 6, so that is a GCS of 15. Woohoo! All right, so now that's great. You know, like one question we could give you on an exam is score this person. But another question we could give you is what are you going to do in different situations depending on what the GCS is? So let's look at these. So the first one says the client has a GCS of 15. What's my priority action? Well, if they have a GCS of 15, that is the maximum they can have. So I'm going to just continue to watch them. No actions needed at this time. Client has a GCS of 7 on the first assessment and goes up to 13 on the next assessment. So for this one, you want to think of what do I want my GCS to do? I want my GCS to go up. So if I want my GCS to go up, then the what do you call it? The move from a 7 to a 13, that's a good thing. If they were a 7 and now they're up to a 13, great, they're improving. Probably just going to continue to monitor and make sure that they're doing okay. Client has a GCS of 15 on the first assessment and it goes down to 8. So we like our GCS high. We like a high level of consciousness. We don't want a low level of consciousness. So the GCS going down is concerning, and I would need to probably call the doctor. We may, depending on the patient, the reason, we'd need to definitely look into what this cause is for this. The next one says client has a GCS of 7. They have a saying, you know, I think that a lot of people in nursing school know is less than 8 intubate. So we do want to worry about their ability to stay awake enough to protect their airway. So I may be looking into stuff with that, seeing like, are they protecting their airway? How awake are they? In my stroke PowerPoint slides, I talk about care of an unconscious patient. You want to think about maybe stuff like that. Because if they're at a 7, they're halfway. I was going to say if they're at a 7, they're halfway to heaven, but that sounds really morbid. So I apologize if that offended you. Rhymes literally go off in my head. So sometimes I wonder if I'm like Dr. Seuss reincarnated, since my head is kind of just a very strange place. But anyway, but a GCS of 7, I'm going to be worried about their airway, how awake they are, and if they're able to remain safe. So I definitely want to keep a close eye. And if their GCS is 7, if that's their baseline, maybe it's okay, but maybe I will have to take action if there's a change. A GCS of 3, this is a patient that is not responding at all. Now, maybe it's okay. Maybe they just had surgery, and so the anesthetic and everything's still on board. Or if this is a change, or you know, if this is for most patients, this patient must be intubated. You know, not I don't want to say must be intubated because there's some patients with a GCS of 3 that aren't intubated, but this patient's going to have a very hard time protecting their own airway and need a lot of support. They're going to be, you know, need like kind of round the clock care, a lot of extra in order to keep them safe and keep them doing okay. And again, it all just depends on, is that their baseline? Do they just have a procedure? Is there something causing that? Or is there something I need to do to intervene? But this is how you want to think, because if it's high, if it's low, if it's in the middle, if there's a change, if it's going up, if it's going down, like what am I going to do about it? All right. That's it for GCS. I'll see you next for headaches.